We have the pleasure of having two speakers to close our day, and it is my great honor to introduce our closing plenary speakers, Dr. Adriann Begay and Dr. Cristina Rivera Carpenter. Dr. Begay is the Navajo Nation Senior Advisor of the Heal Initiative. HEAL stands for Health Equity Action Leadership Initiative. And Dr. Cristina Rivera Carpenter is the Navajo Nation Program Officer of the HEAL Initiative. So please join me in welcoming them to the stage.
Okay, good afternoon. So again, I am very honored to be here today, and thanks Sun and her staff for doing such a wonderful job. So today, Dr. Cristina Rivera Carpenter, Cristina, we're going to talk a little bit about relational approaches in Indigenous health and going from paternalism to partnership. So as I was taught, I am going to introduce myself in the way I was raised. So yate she Adriann Begay and Dr. Betani Bashichin, Katnazani Dashichedo, Ashtia Dashanala. So just to give you a little bit of background, I was raised on the reservation, the Navajo reservation in northeastern Arizona, by a single mom and two younger brothers. And then I took a circuitous route getting into medical school till I was 32 with 3 children. So if you ask the children, adult children now, are any of them in medicine? And they say no, because they saw what their mom went through. And so I stand here before you as an American Indian physician woman, which makes up about less than 0.3% of physicians in the United States. But now I work with the HEAL Initiative. I retired from Indian Health Service in September, and I gave Indian Health Service 21 years of my career. And the reason, one of my big reasons for going to HEAL was because it sort of aligned with my own mission. So the mission for HEAL is to train and transform frontline professionals through building a community dedicated to serving the underserved as their lifelong choice. And for me specifically, building, strengthening, and increasing our Native American workforce is my own personal passion. So global health. Up until I became a HEAL Site Fellow, global health to me meant serving the under-resourced or resource-denied communities abroad. I didn't think of global health as something that we did within the United States. But then we have many people who live in communities of where they're resource denied. We have the inner cities, we have reservations, we have urban areas that have areas of homelessness. And so being a HEAL Site Fellow really opened my eyes, but also gave me a lot of, it taught me a lot about advocacy and leadership. So we're all here today because we want to work together, because we can't work in silos and we have to help each other. And a lot of those is building these relationships and networks that are so important for our people, our vulnerable populations. So in my Navajo upbringing, we refer to each other as 5-fingered beings, and that goes for everybody. And along with our relatives, which includes our Mother Earth, our waters, our air, the air that we breathe, and our relatives who are plant and trees and all its resources, we have to work together and essentially decrease health disparities to improve health equity for all. So many of us have learned and we've been taught about the social determinants of health. And the things that underlie these social determinants of health is the quality and access to education, the quality and access to healthcare, the neighborhoods and its the social constructs that a person lives in or the community lives in. So, when we talk about social and community context, we think about civil participation, if that person's been in prison, and then also economic stability. And so those all kind of are the social determinants of health. But I want to go a step further and talk about the political determinants of health. This is, less recognized than the social determinants of health, but this is actually the root of the social determinants of health. So according to Daniel Dawes in his book, The Political Determinants of Health, he explains the influences behind social drivers of health and wellness, that there are really upstream decisions that benefit certain people and other decisions that will harm people. So the political determinants of health involve the systematic process of structuring relationships, distributing resources, and administering power, operating simultaneously in ways that mutually reinforce or influence one another to shape opportunities that either advance health equity or exacerbate inequities. As an example, political determinants of health, like redlining, where there's upstream decisions whereby minority communities were systematically underdeveloped and leached for profit, ensuring that they remained impoverished. For my own people and for the majority of Indigenous people within the United States, came the landmark law, the Indian Appropriations of 1851, which authorized creation of reservations. So essentially put Native people in usually lands that they thought were, not good lands. But then, fortunately, a lot of times we found out that there was resources like coal and uranium and other things like that. But so just an example of these decisions. One of the things is that American Indians, Alaska Native, if you're federally recognized, and I was really honored to be at the breakout session where they spoke about historical trauma, and where states where people are not federally recognized, so that meaning that they don't get federal resources, but they were stewards of this land. But when you're federally recognized, you have a legal right to health care. You think that would be good, but still, American Indians, Alaska Native suffer from some of the worst health disparities when compared to US all races. And why is this? It's because our healthcare is so entwined in upstream political decisions. The legal basis for healthcare, you can find it in multiple areas. You find it in our US Constitution, you find it in treaties, you find it in executive orders, in multiple court decisions and legal basis, and numerous other laws and acts. But I want to go and just talk about the phases of, 4 phases of federal Indian policy, which include annihilation, assimilation, termination and relocation, and self-determination. For annihilation, we have the Indian Removal Act of 1830. This was the first legal justification and isolation of American Indians. And again, as I said before, allowed the creation of reservations. Assimilation was the US government's goal of transforming American Indian culture to a European American culture. This involved the Dawes Act, or the Allotment Act of 1887. This was forced assimilation and the pressure for American Indians to become farmers or ranchers, and the creation of Indian boarding schools and Indian residential schools. So these are some of the pictures of Carlisle Indian School, where children were taken forcibly. And I want you to imagine you as parents, or you as brothers and sisters, aunties and uncles, or grandparents, for somebody to come to your home and forcibly remove your child from you and take them away, not telling you where they're taking them, but just take them away. And that most likely ended up being the last time you would see your child. And we all know how that turned out. We've seen stories after story of the remains of Indigenous children near these facilities in unmarked graves, and some that are now being returned to their families. Then we had the Termination and Relocation Act. So in 1953, the House Concurrent Resolution 108 terminated some tribes. So that meant greater than 100 tribes were terminated from federal assistance. And a lot of those involved California tribes. Relocation policies then were started in 1955, when the Bureau of Indian Affairs established relocation sites in major cities. So that's why you have a lot of Native communities, like in Los Angeles, these big major metropolitan areas, Los Angeles, San Francisco, Oakland, Denver, Chicago. Again, sort of under the assimilation, where these young adults were told they were going to be sent for vocational training, but a lot of them may not have completed the training, but were not given the means of coming back home. And sometimes when there were young adults who didn't complete their training and wanted to return home, did not, because they were embarrassed, either because of not completing their training or because they lost cultural ties and remained in those areas. And then we get to self-determination. This law authorized Indian tribes to assume responsibility for direct operation of federal programs administered by federal agency, specifically Indian Health Service and the Bureau of Indian Affairs. So that's when you see the creation of what we call tribal or 638 facilities, so that the tribe assumes responsibility for their own operations. And then there's tribal schools or tribal colleges that were created. However, there are still many Indians that believe that self-determination is a sort of a disguise for terminating their responsibility. And you would think that some people would say, no, this is when we can take over, but after multiple different acts and laws that have been passed, there's going to be some level of mistrust. And so there still has a lot of mistrust with the federal government. So, each one of us, if you're anything like me, I need to buy groceries. I need to prepare to make sure that I have enough resources to do home improvement, or if my car breaks down, or I need I need to get something that I you know, need to buy, but this is, I guess this slide really just kind of gives me, but some of us don't have enough. And so we just heard the speaker right before talk about how not having enough resources, not having homes, not having, having food insecurity can drive a lot of the process with addiction. But we all, like I said, we all need resources. We need money, we need equipment, we need staff, we need the mechanic who's going to do the work for us, we need the person who's going to fix our home, and we need space. However, when you look at this graph, it shows that the healthcare expenditures for American Indians and Alaska Natives falls greater than 50% below the recipients of Medicare, Medicaid, 50% below the beneficiaries for the Veterans Affairs, falls 50% below beneficiaries of the national health spending or private insurance, and less than 50% for beneficiaries of the federal employee health plans shown by the FDI or Federal Disparity Index. In essence, there is inadequate funding or spending for the provision of health care for Native people. Another interesting point is that Indian Health Service is discretionary appropriations, meaning that it doesn't increase with inflation, it doesn't increase with the population, it doesn't increase with new technology, and the purchasing power decreases every year. IHS funding is subject to sequestration. So this means that Congress can apply mandatory cuts across the board when the annual deficit is unacceptable. And this is in big contrast to the VA budget. The VA has mandatory appropriations. It is not subject to sequestration. In fact, the VA gets advanced appropriations so that their appropriations, their monies come a year ahead of time. They know what they're going to get. Whereas Indian Health Service budget relies on continuing resolution. So as far as next steps, we heard a lot about what Rupa had said during her initial talk, or her musical. But earlier I introduced myself to you in the way that I was taught. When I introduce myself to you in that form, that really lays out my responsibility to my relatives who may be present. It lays out my responsibilities to you as a Navajo woman. In our language has to do with kinship or relationships. And this is important in almost all Native communities, is our relationship with others. Because it's the relationship that we have among each other that gives us the support that we need. And I think the concept of this relationship or is what has allowed Native people to be resilient and survive 200 plus years of federal Indian policy and 500 plus years of colonialism. So as I said before, as an Indigenous woman, my responsibility includes not only raising my own children and grandchildren, but raising other Native or Indigenous children and making sure that the things that I'm doing is for them. So my work now with HEAL includes this goal of transforming the healthcare workforce by one, role modeling. I would not be standing here in front of you if I hadn't had a good role model. When I was about 13 years old, I saw Dr. Taylor McKenzie, who was the first Navajo physician, while he was doing rounds at our old hospital in Fort Defiance, Arizona. And that was the very first time that I had seen a Navajo doctor talk to a grandpa in Navajo. Dr. McKenzie was an orthopedic surgeon, and I just remember vividly where he went up to Grandpa and he said, "Yat e shiche." Hello, my grandpa. Hashinte. How are you doing? And I looked at that and I just thought, that's what I want to do. But we don't have enough. There's not enough Native physician role models. There aren't enough Native nurses. And that's what we need to work on. So I've done the role modeling. I now have Dr. Leslie Neer, who's finishing her third year, her residency program in family medicine. And I have Dr. Michelle Tom, who is a thriving family practice physician in Winslow, Arizona. And as, again, as Rupa mentioned, that her support system was vital in her work. And this is so true because my own support system has allowed me to be successful. I was lucky to go to the University of North Dakota for medical school, which was really an experience, moving from Tucson, Arizona to Grand Forks, North Dakota, where my first year we had 63 consecutive days of below zero weather. But I went to the program called the Indians into Medicine, and I graduated with 10 other Native American students. And three of us were moms. And we helped to take care of our children together. We had our male colleagues who sometimes we gave our kids to so that they could watch us and the moms could get together and study. I have the Association of American Indian Physicians, where I have physician mentors and that have gotten me through a lot of trials. I had Indian Health Service, and although the funding is not adequate, I was able to serve my own people, and who reminded me daily of the concept of hojon, which is our term for our balance. And they taught me all the time that hojon nahasling, which is it is with beauty again. So the concept of hope and optimism, even when things aren't going well. And now I have Heal. Heal's commitment to solidarity and social justice was shown during our COVID surge. And during COVID, the Navajo Nation had the highest hospitalization and death rate during March of 2020. And they came out with 40 plus nurses and doctors to serve in our community to help us through our surge. So it's really the relationships and the support that we get from another. So I am going to hand this over now to Cristina, and who is my little sister, and have her talk about her journey, her resilience, and the importance of relational approaches. Thank you.
Good afternoon, everyone. Before we transition, I want to thank Dr. Begay. She is an excellent mentor and role model and has been for me as well. So good afternoon. My name is Cristina Rivera Carpenter. I am mestiza On my maternal side, my grandmothers are Lipan Apache and Indigenous from the Mexican state of San Luis Potosi. On my paternal side, my grandmothers are German and Scots-Irish, but that's who I am as an Indigenous woman. I am glad to be living and working on the Navajo Nation since 2009 when I arrived as a new graduate nurse by way of South Dakota. Right, so thinking about relationships, this picture really embodies what relationships mean to me. This was a year ago tomorrow at my reception when I finished my PhD. And these are some of the women who supported me and my children during that time. One of the things that I truly believe is that everything is relational. And I've heard that today with our speakers. We heard Rupa talk to us about the relationships that she's grown over time with community. We heard our next speaker speak to us about the relationship between us and the living world. And this afternoon, we learned about the relationships that we may have in an academic center with the communities that we serve. So to anchor my talk, I want to use share this definition of decolonization. I saw a meme recently and it said decolonization is now the hot sauce we put on everything. And what does that really mean? And I don't know how many of you are familiar with the article, Decolonization is Not a Metaphor, but I'd like to anchor us there. So decolonization is a term that's often used and not often understood, and even less often truly lived. This is my favorite definition. So decolonization is the intelligent, calculated, and active resistance to the forces of colonialism that continue to perpetuate the subjugation and or exploitation of our minds, our bodies, our lands, and is engaged for the ultimate purpose of overturning the colonial structure and realizing Indigenous liberation. As an academic, sometimes I work with the theory of post-colonialism, and I think this is kind of a catch, because for Indigenous people and many people in the world, we are not in a post-colonial landscape. Colonialism continues. Several of our speakers today have talked about the term federal recognition. And here in the United States, colonialism continues in that the federal government determines who and who is not Indigenous in the United States. We think about with what we often call our Latinx population, Indigenous people from our southern hemispheres that once we cross into the United States are no longer considered Indigenous. So something that it is important to understand the historical context and also important to understand our current context. All right, so I'm going to talk a little bit about another concept here, and this is centering Indigenous knowledge. And I truly believe that in order to approach any type of decolonization, we must center Indigenous knowledge. And this is both local and global context as well. When we think about Indigenous knowledge, we think about global health. Indigenous culture, Indigenous knowledge has been health protective and health promotive for a millennium. Indigenous knowledge is evidence-based on its own merit. This is something I came up across very strongly in my own dissertation about wellness among Indigenous women. I think we've talked about the social determinants of health. We've talked about political determinants of health. And I would also ask us to think about cultural determinants of health as we proceed. So these are things that also can include our soil, as we've talked about today, our foods, our medicines, our ceremonies, all of these which impact our health in a positive way, and the removal of which impact our health in a negative way. I want to acknowledge that centering Indigenous knowledge and decolonization are processes. These aren't things to be taken lightly, and these aren't things that are going to be accomplished swiftly. So often we get in a fixed mindset that things should be done quickly and now. For me as a nurse, I see this in our clinical setting. As an academic, I see it in that setting as well. Our funding is set to a time. Our clinical encounters are set to a time. But these processes are centered in deep relationships that occur over time. So what are some of the things that we can do? These are processes that can be done in accompaniment. And to me, what this really means is that we walk this shared path together. As I've said, I'm a guest living in Navajo Nation. And so the way I've seen this as a nurse is that I can bring my clinical knowledge and I meet my patient who have expertise in their own lived experiences and we walk this path together as we support their health and wellness. So I think something that we should think about as we think about global health, often global health can be used as like an extension of colonialism when we superimpose a Western knowledge system and invalidate Indigenous knowledge systems in many settings. All right, so I'd like to talk to you a little bit about trust. And Dr. Begay brought this up. This is a picture of my grandmother on the top, my mom on the bottom left, and then myself on the bottom right. Each of these pictures were taken shortly before we each became mothers. And so I'd like to share a little bit about myself with you guys. The experiences of my grandmother live in me. The experiences of my mother live in me, and they live in my children, some of whom are in this audience with us today. And each of us in different ways have experienced situations and where trust was broken with our healthcare system and our medical system and our academic systems. So I think to me, this is something like that's very personal. So trust takes time. And if we're approaching our populations and our communities in a way that is of paternalism, paternalism does not promote trust. So as Rudy mentioned, sometimes we may even work in these systems that are killing us. Thinking about our educational system, our healthcare system, our academic systems, how could we expect our patients and our communities to trust us when we may be complicit in some of these systems? Our patients and our communities don't owe us trust. So again, everything is relational. To build trust takes time. It takes deep relationships. This trust should be bi-directional. We can't go into a setting and expect trust to just happen from our patients, from the community to ourselves. This is something we need to trust our patients and community and really center their lived experiences as well. And thinking about things like co-creation rather than ownership. As a researcher, this has been the approach that I strive to take, co-creation in the research process. And thinking about these relationships being more important than checkboxes. Rupa showed us the checkbox of social determinants of health. And so often we have a 15-minute clinical encounter, or we have set grant funding, everything has to be done in that time. And these approaches don't support deep relationship building. So it's up to us to make those small changes in our own lives and in our systems to support this. So again, everything is relational. And I think of one way that we can begin to kind of change this paradigm is thinking about the concept of relational accountability. This is something that was central to my dissertation. So relational accountability is a concept that Sean Wilson, who's a First Nations researcher, wrote about in his book, Research is Ceremony. So I'd like to describe it a little bit. A lot of times when we work in academia, when we work in health, how do you approach your patient? Do you approach them as a relation? And so oftentimes what my experience has been is that we do not. And so I think by even that small shift, I see my patient as a relation. This person is not my research subject, they're my relation. It fundamentally shifts that relationship. Another thing that we can think about is accountability instead of responsibility. We may think that as a doctor, a nurse, a healthcare professional, we're responsible for our patients. We're actually accountable to our patients. We're accountable to our communities. So by seeing one another as relations, by focusing on accountability rather than responsibility, we can grow deep relationships with one another, with our patients, and with our communities. So where do we go from here? One of my favorite quotes is by Fred Hampton, and it's, "Theory's cool, but theory without practice ain't shit." So how do we live these things? We're going from concepts to our daily life. So I'd like to expand a little bit on what Dr. Begay shared about Heal partnering with Navajo Nation. So we see an article that was recently published, and this is lessons learned from an academic medical center's response to the COVID-19 pandemic in partnership with the Navajo Nation. And so I'd really like for us to focus on this in partnership. Heal had been working with Navajo Nation. We've had fellows in Navajo Nation since 2015, I believe. And so it was this deep engagement, relationship building, and solidarity that allowed this partnership to happen and be responsive to the moment in COVID. So this wasn't an outside org swooping in to save the day. This was not paternalism. This was true partnership working in solidarity. So from bringing people to screening applicants, making sure they were coming for the right reason, because as we know, a lot of harm can be done with good intentions. So making sure that people were coming truly in solidarity with humility. This poster here in the middle on the top is my chair for my dissertation and one of my mentors, Dr. Michelle Kanjan. In this picture, we're in London. We're sharing results of a study. The study is focused on ceremony and was done with the support of the Navajo Nation IRB and the Medicine Men's Association. Because this deals with ceremony, there are certain details that are withheld. We don't share the name of the ceremony. We're respectful of the ceremonial process. But what we showed is that, like we've said, these cultural determinants of health can really help people and are things that we actually should continue to include in our mainstream health systems. In Navajo Nation, we often have traditional practitioners on our in-house. We can send referrals to them just like we can send referrals to a specialist. So I think this is something that we can continue to strengthen and to grow in our communities. Another example is the top picture on the right. These are my former nursing students with the American Indian Nursing Program. This is actually a day where we did our respiratory lecture, which was 4-hour lecture blocks, in nursing school. And this one we went outside. Like Rupa mentioned this morning, that our forests are our lungs. We went and we walked and we hiked and we were spending time within the living world as we learned about our lungs and oxygen exchange and ventilation and perfusion and the mismatches and the disease states that can happen. So this is a little bit different approach to teaching, being out in the living world, truly connecting with the living world, small changes that we can accomplish. Here on the bottom right is at our Heal graduation in 2016. And this is where we bring together people from all over the globe. We're united in solidarity by our values and by our ethics. And then in the bottom middle picture, you'll see a familiar face of Dr. Begay. You'll also see Val Teneker, who's also a nurse and works in infectious disease, and Dr. Marla Yazzie, who is an amazing pediatrician. So these are colleagues that I'm also proud to call my sisters. So again, relationships that grew and were built over years and over time. So now we may think, now what? Where do we really go from here? So I'd like to talk about some of our responsibilities. When we work in global health and we work in communities that are not our own, it's our responsibility to learn the context of the community, not to expect people already in the community to do our emotional labor and our intellectual labor. We have the ability to read, to find resources and things like that. This happens pretty often in my setting, and it's really up to us. So what is the context of the community that you're partnering in? What's the history of that community? Dr. Begay shared with us both the historical and current context of IHS. How many people take the time to actually learn about that when they come into community? So another thing that I want to think about with global health is what's our focus in our work? If we're not supporting building local capacity, are our global health initiatives truly equitable? I think it's something that we should sit with and we should think about as a community. I like to think of this as a process of centering and recentering, of learning and unlearning. A lot of times, like we said, we're in our clinical or in our academic minds. We think there should be a clear start, a clear end, and everything should happen in a timely manner. And these processes don't work like that. I would encourage each of us to think about critical self-reflection. When we're working in communities that are not our own, or even communities that are our own, this is an important part of the work that we do, working in global health, and when we do work focused on equity. Where are we in the work? Where is this process? What are our motivations? How are we partnering with community? Different things like that, and actually making this a part of our process. It's been a long day, a long afternoon, and I'm thankful that you guys are all here listening to Dr. Begay and listening to myself at the end of the day. And I just want to share a few thoughts about today. Today, Rupa talked to us this morning about many things. We talked about relationships, we talked about roots, and to me, relationships are the root. This is how we stay together, we hold things together, and we grow together. I think about partnership rather than co-opting. I think about curriculum development that's called food as medicine that doesn't credit Indigenous people who know that food is medicine. I think about being aware of the harm that can come from good intentions, recognizing Indigenous knowledge. Vandana talked to us this morning about access to healthcare being justice, about the earth and humans not being separate. Our health and our wellness is tied to the health and wellness of the living world. Rudy talked to us about solidarity and humility, and although he may not have used this term, I saw the theme of relationality in his talk. And when we think about things like substance abuse disorders, thinking back, I believe that trauma is really one of the gateways. We think about historical trauma, intergenerational trauma, and ACEs. We talk a little bit less about PACEs and the things that are protective. And Dr. Begay again shared with us the historical and current context of the Indian Health Services and the experiences that Indigenous people have had in this country. Again, access is justice. Like Dr. Begay, before I began as a Heal Fellow, I didn't clearly see that the work we did in Indian country as being global health. I too had this idea that global health is where you go somewhere else. But I think that's really problematic. There's a lot of othering that happens in that process because we're really not separate from one another. Again, wellness is relational. So my health and my wellness is directly connected to each of yours. My health and my wellness is directly connected to the animals, the water, the minerals, and the living world. So I think when we think about global health is us. It's each one of us in the room, each one of us in this room today, and each one of us in this world today. So I'd like to leave us with that. Vandana talked about a new paradigm, and I really think that this is only the beginning. So I'm appreciative that we had this space, that you guys again shared this afternoon with us. Thank you.
Thank you, Dr. Begay and Dr. Rivera Carpenter, so much for your talk. And it has been an absolutely incredible day. So thank you so much for being here. And I would like to point out that I love the theme that has emerged from all of our plenary speakers today that show us less greed and exploitation, but instead more listening, more learning, more caring, and more love for each other and the natural world surrounding us is what's needed to begin to heal our planet and the health of the communities that are dependent on it.